morning. Today we are going to the second edition of our clinical class. This will be about the examination of the swelling. Okay. Before starting the class itself, we want to give you a little definitions about the swelling and all. What is the definition of the lump? Many often we interchange the lump and swelling. What is swelling? What is the lump? Lump is the weight mass of body tissue. That is the definition. Weight mass of body tissue. Then what is swelling? Any enlargement or protrusion of body in the body is called a swelling. Okay, which may be like what you usually see, the tumors. Everything is part of a comes under the definition of a swelling. Okay. Another set of things I would like to define before starting the class is the types of swellings. Any swellings in the body can be classified into five types. Okay. That is congenital, that means it's present from birth. Traumatic, that is it's caused due to trauma. Then the inflammatory, which is caused due to inflammation. The neoplastic ones, which could be benign and malignant. And the fifth one is the miscellaneous group, which can be miscellaneous group includes that of the degenerative and other types of things. Okay. So this is the as a preface I want to tell you, because after the class is over, you should be able to categorize two things. One, the anatomical site of the swelling. Two, categorize the swelling into one of these groups. And three, possibly three, a pathological aspect of the swelling also. Okay. So with this in mind, we start the examination of a case of the swelling. As in any other case, we start with history. You should ask the name, age, everything about the patient. You should get into a rapport with the patient as in any other case. Then you get into the case. You ask how long the swelling is there. What is the present complaint? Patient tell you there is a swelling. Some part of the body. What is the duration? It's very important. As I told you initially, a congenital swelling can be there from birth. A traumatic swelling, there will be history of trauma recently. A neoplastic swelling also could be a recent swelling. Similarly, you should ask the duration. If it's present since birth, automatically we think about a congenital swelling. Okay. Second question you should ask is the mode of onset. How did he notice it? That's the other way of putting this question. How did you notice the swelling? The patient noticed accidentally. Very often, for example, a breast carcinoma, the patient will tell you, I just noticed while I was taking bath, or somebody else noticed it. That is a swelling which was not having any discomfort to the patient. So you should be a little more worried about it. The patient noticed the swelling because of pain or any other discomfort is a little better as far as the malignancy part is concerned. Okay. So patient is not having any discomfort, no pain, needs to be a little more careful in evaluating the swelling. So mode of onset is very important. What are the other symptoms about this patient, about the swelling this patient is having? Is the patient having any difficulty due to the swelling, like movement or swallowing? If the swelling is in the neck, is there any problem with swallowing? Or if it's near a joint, is there any problem in moving the joint? Or the very important question is, as I mentioned earlier, is the pain. The pain is there. If the swelling starts with the pain, that could be an inflammatory or traumatic swelling. Okay. And malignant swelling almost never starts with pain. Pain is a late phenomenon in a malignant swelling. So if the patient is not having pain, you should be a little more careful. Okay. If the patient is having pain, you should ask the nature of pain. If it's a throbbing pain, it may be an inflammatory pain. Okay. A neuralgic pain, like it is impinging on the nerve, could be a neuralgic type of pain. And the site of pain, where exactly there is over the swelling, or is it some radiation distal to the swelling? If the pain is radiating somewhere. And the time of onset. Is it the time of the pain started after the swelling, before the swelling, as I mentioned before? Is it related to the swelling? Okay. Third, another group of questions you should have. Progress. How is it progressing? Suppose the patient is telling you this is there for the last 5 months. How is it progressing? Is it slowly progressing? Is it remaining as such? Is there a recent rapid progress inside? Patient will tell you the swelling is there for the last 6 years. The last 2 months or 1 month, there is a rapid progress, which will raise a suspicion. Okay, there's something going on. Is there any malignant transformation going on? Here I would like to tell you there's a difference between a sudden increase in size and recent rapid increase in size. Sudden increase in size means within a few days swelling increase in size. So that is a feature of probably bleeding into a swelling, a degeneration or infection. That is not a feature of malignancy. Usually it's not a feature of malignancy. Malignancy will be a recent rapid increase in size. That's the difference. In the last few weeks or 1 or 2 weeks, or a month, the swelling is increasing in size. The rate of progression is more than that of what was before. Okay, so that is an important history issue. How is it progressing? Then, suppose patient is having a swelling. Is there any other? You should ask the patient. Is there any other similar swellings in the body? There are so many conditions which can be multiple in the body, like a multiple lipoma, neurofibromatosis, even lymph nodes. Patient is having swelling in the neck, and he is feeling I have swellings in axilla, so that will automatically give you an idea. We are dealing with a case of probably a case of multiple lymph node enlargements or subcutaneous swellings like lipoma, neurofibromatosis. So ask about other history of our other swellings in the body. Then, any history of previous treatment to this condition? Is it recurrent? Sometimes some swellings can recur, like a malignancy which was not properly treated before, or a malignant transformation, which earlier it was a benign swelling, but at the side there is a malignant transformation taking place. So that can give you an idea. Maybe it is a malignancy which is recurrent or improperly treated. For example, a cyst, which was earlier it was a cyst. You try to remove it, but part of the cyst wall was left behind. So you can have a recurrence of the cyst. Okay. So that is a history of a previous surgery or any treatment on the same site. Any other constitutional symptoms like fever, loss of weight, and all these could be a part of a chronic inflammatory process or a malignant process. Okay. So that will complete history of present illness. And you should always ask about past history and family history of the patient, any history of tuberculosis or any malignancy. Certain malignancies can run in the family. So neurofibromatosis can run in the family. So you should ask about a brief family history of all this before you go into the examination part. Okay. So this is the brief. I'm just giving a brief idea about the history taking. You may have to elaborate on every point I have mentioned, and you have to put more effort into understanding each and every point. Okay. Now, going to the examination, you complete the general examination. I'm only talking about the local examination of the patient. After proper consent, the last class also mentioned about the getting proper consent and privacy and all the proper exposure and proper bystander, all those things you should follow, and also follow certain good manners to explain what you're going to do, introduce yourself, who you are. All these things are essential in every case. Okay. So after that, you go into local examination after proper exposure. Now you see local examination, inspection. You go into the inspection. Where exactly the swelling is? Okay. This may give some clue about the diagnosis. For example, swelling in the outer canthus of eye. I'm just giving an example, which may be this site of embryonic gland fusion, isn't it? Maybe you think about there are more swelling in front of the neck. Okay, maybe you think about a thyroid swelling. Similarly, swelling is in the groin. Patient inspection, you are seeing a swelling in the groin. So you might consider about groin swelling. A swelling in the scrotum. You may think about a scrotal testicular swelling or a hypophysis, something like that. So, say exactly where the swelling gives you immediate idea about the diagnosis. What is the color of the swelling on inspection? What strikes you? The color, isn't it? Color of the skin over the swelling. Sometimes because skin may be normal in majority of the swellings, but sometimes it may be some discoloration like edema and redness, angry looking swelling. This may be swelling may be an inflammatory one. Or maybe blackish color there on the swelling, maybe it's a nodular swelling, blackish color, maybe think about some melanotic swellings and all these things. Okay. Or maybe a reddish or purplish swelling with a purplish hue for the swelling. Maybe you think about a vascular swelling, a hemangioma, and things like that. Okay. So color of the swelling or skin of the swelling is important. Shape and size you have to note again. What is the shape of the swelling, size of the swelling, or surface of the swelling. These surface is better palpated than inspected, but sometimes the surface will be very obvious, maybe smooth. You can see the nodularity or bossulations on the surface, which may be inspected also. So you note that. Edge of the swelling, edge, that is the periphery or edge or margin. This is not the edge or margin we talked in the last class about ulcer. This is different. Edge is the periphery of the swelling. How is it? What you look for is it well defined or not? Can you see all the edge or margin of the swelling? Is it well defined? In case of benign swellings, usually the edge will be well defined. The malignant or inflammatory ones, the edge will be ill-defined edematous. It will emerge with the circumvention. Okay, the edge and margin is very well defined. You have to see. Then the number, how many numbers are there? You should always look for. There are multiple swellings, as we mentioned before. Certain conditions could be multiple. Then you look for certain specific characters like a pulsation. A swelling, is it pulsatile? On inspection, you have to put a little effort. Sometimes you need to really do nothing and examine and inspect with a lot of care to see the pulsation. See whether the swelling is pulsating. So that means it could be a rising artery or maybe a transient pulsation. Then certain specific things like movement with respiration, deglutition, and movement with protrusion of tongue, which will be done only in certain cases. Don't mention a case as swelling in the leg. You are mentioning about movement with respiration, movement with deglutition. It will be very, very stupid to say swelling is not moving with the deglutition and swelling situated in the right side. Don't do that. Only specific situations you should apply this type of question. You ask these questions. Then same is the case with impulse on coughing, reducibility, and all these things. Okay, these are also not done in every case. As and when you discuss the case of hernia, we will come across such questions. But these are, as we are discussing a case of swelling in general, I'm enumerating the number of questions you need to ask in every case. Okay. Okay. Now, skin over the swelling is we mentioned about the color. Other features of the skin over the swelling. Is it not only the color? Is it edematous? Is the skin broken down like ulcer? We discussed about ulcer in the last class. Is the skin is broken down? Okay. Is there any ulcerations or any fungation of the skin is happening? That indicates probably a fast-growing tumor, swelling, or maybe an inflammatory infected swelling also can break down the skin, or a fast-growing neoplasm which can break down the skin. Edema indicates there is again a fast-growing process, maybe an inflammatory, or even sometimes in neoplastic conditions. Sometimes you get the skin is very much edematous and pure orange in color. You know, pure orange is due to like an orange peel, which very much described in carcinoma breast. But it's not specific to carcinoma breast. Any condition where there is skin edema and blocking of the dermal lymphatics and puckering produced by the insertion of the sweat glands ducts can produce pure orange. It just indicates there is a lot of edema of the skin. Okay, due to some reason. Also look for, inspect any pressure effect. Suppose there is a large swelling in the left groin. So always look at the distal part of the limb for any pressure effect. This swelling may be sitting over the humeral vein or the lymphatics of the leg, or maybe artery, compressing of the artery. So look at the distal part of the leg. Is there any edema, any neuromuscular deficit which is inspectable? So look for that. This again may be more evident by a palpation. Okay. So that will finish somewhat a palpation of the swelling. So you have described everything about the swelling, surrounding areas, and specific points as and when you have to mention, and also distal part of the swelling, distal aspect of the lymph or whatever, or any pressure effect, and skin over the swelling, etc. Okay. Next is palpation. As in any other case, palpation should always be very gentle. Should start with a gentle examination for any rise of temperature and tenderness. Okay. If the tenderness, temperature is usually mentioned by the dorsum of the fingers, like gently palpate and touch the dorsum, or like this, you touch the swelling in the dorsum and then feel for any rise of temperature. Then, and tenderness also should be gentle. If the swelling is quite tender, what ideally you have to be very gentle with this further examination, otherwise you will be inducing a lot of pain to the patient. And also to give you some clue regarding the diagnosis also. Surface, palpation, I told you surface is usually palpated. You should palpate gently around the swelling to get the surface. It could be smooth as I mentioned drawn here. It could be nodular or bosselated, or sometimes it could be just irregular. Nodular surface you may get in some cases of lipoma, irregular surface you may get in malignant swellings. Okay, lobe lesions also sometimes you get in lipoma. Smooth swelling surface you may get in cystic swelling. Smooth surface will be very smooth. Sometimes in some neurofibroma and all you may get a smooth surface. So surface is very important. It should be palpated. Edge again you have to palpate. You palpate the edge. Is it well defined? Can you palpate all the edge, all over the edge, all 360 degree? Can you palpate the edge? It is very well defined or not? Okay. What happens when you palpate the edge here? Sometimes a well-defined swelling like a lipoma, once you palpate the edge, it will slip away from it will, because it's very well mobile and encapsulated swelling, it will, when you press here, it will move. This is called a slipping. This can very well be mistaken for a fluctuation. Okay, so you should be, when I come to the fluctuation, I will describe further. It is not fluctuation, it is a slipping. This whole swelling is slipping away from your examining finger. This is a slipping, slip side. Okay, sometimes the swelling is containing some sort of semi-fluid substance. When you press here, your hand will go, finger will go into the swelling. A little bit yielding. This is called yield side. Because the swelling is not clearly solid, it contains semi-solid substance or semi-fluid substance. Your finger will go get into the swelling. This is called the yield side, yielding. The examined swelling will yield your palpation. Okay, palpation. But as you when palpate the surface, you can also know the consistency of the swelling is very important. Soft and cystic consistency, sometimes very soft, cystic. Cystic means fluid is there. Okay. Or with this just soft, without any fluid. It is called a lipoma, or you will be very soft but fluid. How do you differentiate whether it's fluid or not? If it's fluid, you may get a fluctuation. Isn't it? How will you look for fluctuation? At this point, I think I should explain how will you look for fluctuation. Suppose this is the swelling. Some people will keep one hand here and press here. And you say, okay, this is fluctuation. No, this is not fluctuation. This whole swelling is moving and pressing on this finger. This is not fluctuation. The whole swelling is moving. What you should do, fix the swelling like this with these two hands. Put one finger here, put one finger here, press here. Then you will see this hand is raising because of it. So these four fingers are fixing the swelling. And you are examining with these two fingers so that when you press here, this finger is getting raised. This a physics law called Pascal's law. Okay. Suppose the swelling is very small. You can't fix with four fingers like this. So we can do like this, and so the swelling is fixed, and one of these fingers can be used to press here, and so that you will feel the pressure with the other finger like this. So you don't have space to keep all those fingers here. So like this you can do. And if the swelling is very small, it's still very small, and you feel sometimes fluid inside is very tense, the swelling may appear as a firm swelling. So what you do, however firm is the most softest area is always in the middle of the swelling. So you press here, you fix the swelling, and press in the middle here. Your finger will yield and go into the swelling. That's called Paget's test. Okay, so these are the tests by which you know it's a swelling cystic. Okay. Then sometimes swelling may not be cystic, but still soft, maybe lipoma. Sometimes it may be firm, like in the case of fibroma. Sometimes it may be hard, like in case of malignant swellings, or maybe bony swellings, maybe bony hard, very hard swellings. Okay, so consistency will give you an idea what type of swelling you are dealing with. Okay, fluctuation we already mentioned about it. So it's very important to know how you do the fluctuation. Many times the examiners would like to see how you do the fluctuation, and you will do the first way method, that is pressing the whole thing, and you will say it's fluctuation. No, that is not fluctuation. First, you should remember, fix the swelling, then do the fluctuation test. Okay? Right. Now, again, some of the other specific tests like impulse on coughing and reducibility is not necessary in every case. Like if you are dealing with an inguinal swelling, groin swelling, or any hernia case, you should look for the impulse on coughing and reducibility, which will be dealt with by whenever I discuss a hernia case. And compressibility. What is the difference between compressibility and reducibility? You press on the swelling, it goes in, and on releasing, immediately the swelling comes back. That is compressibility. Usually compressibility is seen in vascular swellings like AV malformation or hemangioma and like that. Whereas in reducibility, if you press it, it goes in, you release the hand, it will not come out immediately. The patient will have to apply opposite, like a coughing, straining, for the swelling to come out again. Okay, so you have to differentiate between compressibility and reducibility. Pulsatility, yes, you keep finger. How will you look for pulsatility? Keep two fingers. You will feel your fingers are getting raised. How do you know whether this is a transmitted pulsation or expansive pulsation? What the books say, if it's just a transmitted pulsation, your fingers will raise like this. But if it's a expansive pulsation, that means it's arising from an artery, your fingers not only will be raised, it will go like this, expand. Okay, because the pulsation directly from the artery, your fingers will go like this. Whereas in transmitted, it will be just raised, and the intensity of the pulsation also will be less in a transmitted pulsation. Okay, so you should know the pulsatility. Then always look for the plane. How you, very important as swelling is described. What is the plane of the swelling? From which, what are the planes? Suppose we are getting, for example, take an example of a left thigh swelling. Okay, is it from the skin? Is it from the subcutaneous tissue? Is it fixed to the fascia? Is it from the muscle? Is it deep to the muscle? Is it from the bone? Or any other neurovascular structure? Okay, so just for sake we keep it a soft tissue swelling. If it's from the skin cannot be separated from the swelling. Okay, if it is not from the skin, only subcutaneous skin can be separated. And how do you know it is not fixed to the muscles? You contract underlying muscle. Okay, and see. If it is not fixed to the muscle, the swelling will be still freely mobile even after contracting the muscle. Okay. If the swelling is super fixed to the muscle, what happens? The muscle, once you contract the muscle, the swelling will be reduced in mobility, especially across the line of these muscle fibers. So it will be less mobile. If the swelling is deep to the muscle or intramuscular, what happens when contracting the muscle? And also one more thing, if it is superficial to the muscle on contracting, it will become more prominent on contracting the muscle, and mobility will be the same. If it is deep to the muscle or within the muscle on contracting the muscle, the swelling becomes less prominent and less mobile. Okay, clear? Right. And if it's from the bone, it will be immobile from the beginning itself. And okay, if it cannot mobilize even when the patient is in a relaxed position because its bone is a fixed structure, it will not be mobile at all. So this way you should try to fix the swelling, the plane of the swelling. Any swelling it is, whether abdominal, neck swelling, arm swelling, wherever it is, you should try to fix the swelling in one of these planes. Okay, that's very important also. Okay, so now the examination of swelling, whatever is over, you may have had an anatomical diagnosis, you may have some type of swelling, whether congenital or traumatic, whatever it is that you have. And on examining, after completion of all these, you may have had some pathological clue about the diagnosis also. Okay, but the examination is still not over. Whenever there is a swelling, always see the regional lymph nodes, as I was mentioning in the last class. Selected cases, you may have to focus like a hernia to know whether there is any gas-filled structure inside. You can focus and see. Auscultate. If you are dealing with a vascular swelling, you need to auscultate and see whether there is any buoy or any vascularity. Okay. Then, if the swelling is near a joint, you should see whether the patient is able to move the neighboring joints and the limb, distal limb, any neurovascular deficit or not. There are not. Okay. Look for any pressure effect, like any edema, any distal neurovascular deficit. If it's, for example, a swelling in the groin, can compress upon the nerves, the venous system, artery, lymphatics. So patient can have distal edema, distal neurovascular deficit. Okay. So don't forget about all these points. So then only after mentioning all these points, examination of flash swelling is over. Okay. And few points I will tell you. If the swelling is on the arm, you have to expose the patient properly. Patient may be having multiple similar swellings in the back. Patient may not be bothered about that. He may not tell you. So unless you expose the patient properly, give a patient. So head to foot examination is very important in every case. This may be a particular example how important a head to foot examination is. Probably a case of swelling, the examiner is only interested in whether you are picking up other swellings. Okay, this may be no obvious lipoma here, whether you are picking up other swellings, that may be the task given to you. So don't forget the basics. Follow the steps which I have described. Okay, even if it's a small case, it is. Don't forget to examine the patient as a whole, consider the patient as a whole, and do all steps for examination which I have described here. And finally, come up with a reasonable diagnosis. So diagnosis may be not very important at this point. Okay, reasonable diagnosis, and that will be an end of the case. Okay, hope you enjoyed this class. Hopefully, I sincerely hope it was as useful as the last class to you. And if you like it, we may continue with other classes. Okay, sit back and enjoy. Thank you very much.